Good evening. Let's discuss about febrile neutropenia today. So starting off with its definition, it is the occurrence of fever during a neutropenic episode. So occurrence of fever during neutropenic episode in a child with oncological problem. Okay. So this definition has two components. One is fever, another one is neutropenia. So what is the definition of a fever in a febrile neutropenic patient? So definition of fever in febrile neutropenia. So it is nothing but a single oral temperature of more than 101 degree Fahrenheit. It is a single oral temperature. A single oral temperature of more than 101 degree Fahrenheit, or it can be a temperature of more than 100.4 degree Fahrenheit on two separate occasions. Okay, on two separate occasions, which is separated by about 1 hour. So it can be a single oral temperature of more than 101 degree Fahrenheit or a more than 100.4 degree Fahrenheit on two occasions separated by at least by 1 hour. Okay, so this is the definition of a child with fever in a febrile neutropenia. What is neutropenia? So neutropenia is defined as when the absolute neutrophil count, this is ANC, is nothing but absolute neutrophil count, is less than 500 cells per millimeter cube, or when ANC is less than or is expected to fall to less than 500 cells per millimeter cube during the next 48 hours. So it is defined as less than 500 or when ANC is expected to decrease. When it is expected to decrease to less than 500 per millimeter cube during next 48 hours. So this is the definition of neutropenia. We will see the severity of neutropenia. So next is severity of neutropenia. Here the normal ANC, so the normal absolute neutrophil count is 1500 to 8000 cells per millimeter cube. You call it as neutropenia when the ANC is less than 1500 cells per millimeter cube. So this ANC can be mild, moderate, severe and profound. So mild is defined as when the ANC, that is absolute neutrophil count, is between 1000 to 1500 cells per millimeter cube. Moderate is defined as 500 to 999 cells per millimeter cube. Severe is when it is less than 500 cells per millimeter cube, while profound neutropenia is less than 100 millimeter cube. This is the severity of neutropenia. So definition of febrile neutropenia is occurrence of fever during a neutropenic episode. So definition of fever we have mentioned here, and definition of neutropenia we have mentioned here, and severity of neutropenia is also being mentioned. Next we will see the common organisms in a child with a febrile neutropenia. Okay, so next is common organisms. So common organism that is causing infection in a child with febrile neutropenia. Okay, first group is gram positive cocci and bacilli. Is gram positive cocci and bacilli. In this, first is Staph aureus. Next one is Staph epidermidis. Third one is Enterococcus. Fourth is Corynebacterium. So among gram-positive coccobacilli, cocci and bacilli, we have Staph aureus, Staph epidermidis, Enterococcus and Corynebacterium. Next group, gram-negative. In gram-negative organism, we have E. coli, second Klebsiella, third is Pseudomonas. Okay, so this is among the gram-negative. Next is fungi. Among the fungi, we have Candida. In Candida, most common will be non-albicans. Second, Aspergillus. Aspergillus is common in patient with hematopoietic stem cell transplantation. It is common in children who have undergone hematopoietic stem cell transplantation. Next among virus. We have influenza, RSV, that is respiratory syncytial virus, rhinovirus, parainfluenza, fifth is adenovirus, and sixth will be corona. Okay, so these are the most common infections that is causing infection in a child with febrile neutropenia. Next, we'll go into the risk assessment. So we are going to categorize the child with the febrile neutropenia as low risk and high risk. Next is risk assessment. We have low risk and high risk. So first, duration of neutropenia. So how many days the child is with neutropenia? So when it low risk child is less than 10 days. When the child with neutropenia is present for more than 10 days, you categorize it as high risk. Next is depth of neutropenia. That is the severity. So in child with low risk, they will be having more than 500. In child with high risk, they will be having a profound neutropenia, that is less than 100. Next, what is their diagnosis? That is primary diagnosis. In low risk child, there can be a solid tumor, while in high risk, it is mostly acute leukemia. So it is mostly acute leukemia, child with acute leukemia in induction phase. Okay. Next, disease state. Whether it is newly diagnosed or a child with a relapse or a refractory malignancy. So in a low risk child, it will be a new one, a newly diagnosed one. In a child with high risk, it can be a relapsed or a refractory. Next, what are the associated features? Associated features. Low risk child will have nothing, while in high risk, they can present with hypotension, hypoxia, altered sensorium, respiratory distress, mucositis. Next, abdominal symptoms. Okay, this is the risk assessment. Next, how are we going to evaluate? What is the examination of the patient? So, examination of a child with neutropenia. So, first is basic vitals you will be seeing. In vitals, look for sensorium. Whether child is alert or verbal or pain responsive or unconscious. Next, you have to be looking for the temperature, peripheral pulses. Fourth, you have to look for the tachycardia, heart rate, whether the child is presenting with tachycardia or not. Fifth, BP, respiratory rate, urine output, and saturation. Okay. Next is the local examination. Locally you have to find the focus of infection. So you look for, starting off with the oral mucosa. Any candidiasis is there or not, or mucositis, or any aphthous ulcer. Next, in respiratory, you have to look whether the child is having any tachypnea, crepitations, wheeze. Next, if the child is having any urinary catheter, then you have to look for catheter site infection. Not only urinary catheter, even any IV line or central line, you have to look for catheter site infection, whether there is a redness over the catheter or not. In abdomen, whether there is child is having a tenderness on palpation. Then you should not forget to examine the rectal region, whether there is any perianal ulcer. If the child has undergone any surgery for any solid tumors, you have to look for surgical site infection. So surgical site redness is present or not. Lymphadenopathy, any skin infections. Okay, it is also being included in this focus of infection. Any ear infection. CNS. In CNS infection, you have to look for meningitis. You have to look for neck stiffness, headache. The child can have headache with neck stiffness, and you have to look for the symptoms for raised ICP symptoms. Anything is present or not. Okay. So these are the ways you have to look for a focus of infection in a child with neutropenia. Next, investigations. So going on with the investigations. First will be our, as usual, complete blood count with a differential count, peripheral smear. Next you will be looking for RFT, LFT, serum electrolytes. Our important investigation will be our blood culture sensitivity, CRP. Culture sensitivity, if the child has any central line or peripheral line, you have to take the sample from there. So culture sensitivity of the peripheral and the central lumen. CSF culture sensitivity, if you detect any meningitis in the patient. If the child has oral ulcers, you have to send swabs. Or any wound, you will be sending swab from that side. Next, urine culture sensitivity, blood culture sensitivity, CSF culture sensitivity if the child has the symptoms of meningitis. Next, urine culture sensitivity. Next, when will you be doing the imaging studies? And what are the imaging studies you will be doing? So among the imaging studies, you will be doing chest X-ray if the child is symptomatic. Second, HRCT is being advised only if the child has a persistent fever with the pulmonary symptoms on examination after the initiation of empiric antibiotic therapy. So you will be looking for HRCT only even after starting your empirical antibiotic therapy. The child is having persistent fever with pulmonary symptoms, pulmonary signs on examination. Okay. Next is CT abdomen if the child has typhlitis, or to rule out typhlitis. CT brain if to rule out raised ICP. Okay. So these are the imaging studies you will be doing. So in investigation wise, as usual, normal basic investigations you will be doing. The important investigation in child with febrile neutropenia is blood culture sensitivity and any swabs, culture sensitivity when the child has any wound or any oral ulcers. So this is about the investigation part. Next we'll go on to the treatment part. Management. For a child with mild case, In a child with low risk, that is with a mild case, low risk for developing infection related complications during the course of neutropenia, you can start them on oral antibiotics. So in a low risk child, you can start them on oral antibiotics, or if you start on oral antibiotics, you should have a follow up of the child. You should ask the child to come every day to check for their examination, to check for any signs and symptoms have been in progress or not. Suppose you don't have the follow up of the child, or you are not able to follow up, their house is far away, then you can better admit the child and start on a IV empirical therapy. So what is the preferred oral antibiotics for this patient is oral ciprofloxacin with amoxiclav, or oral cipro with clindamycin if the child is penicillin allergy. Okay, this is for mild case. Next, empirical therapy. So very important is you should start the antibiotic immediately within 1 hour after the blood culture sensitivity have been taken. So you will be, this is important one, you should start antibiotic, that is empirical antibiotic, within 1 hour after taking blood culture. If you are not able to take blood culture also, you should immediately start the antibiotic therapy for that patient. Okay, that is very important. In antibiotic therapy, we have monotherapy, dual therapy and combination therapy. First, starting off with the monotherapy. What are the drugs used for monotherapy? So you can use anti-pseudomonal cephalosporins. In anti-pseudomonal cephalosporins, you have cefepime and ceftazidime. Next, you can use carbapenems. In carbapenem, you have meropenem or imipenem with cisplatin. Third is anti-pseudomonal penicillins. In anti-pseudomonal penicillin, you will be having piperacillin tazobactam, that is Piptas. So these are the drugs can be used for monotherapy, that is initial empirical treatment. Next, for dual therapy, for if you suspect gram-negative organism, for gram-negative infections, you will use beta-lactam antibiotics or carbapenem with aminoglycoside or fluoroquinolones. Okay, this is for gram-negative infections. You will be continuing for 10 to 14 days. Duration will be 10 to 14 days. Okay. Next is the combination therapy, triple therapy. In combination therapy, it is nothing but along with this dual therapy or monotherapy. So along with the mono or dual therapy, you will be adding vancomycin. Okay. So this is the combination therapy. Next, we have to look for in which child you will be using antifungal or antibiotic prophylaxis. So in which child you will be using antifungal or antibiotic prophylaxis. So prophylaxis is not indicated for low risk patients. So prophylaxis is not indicated for low risk patients. You can use fluoroquinolone prophylaxis for high risk patients with a prolonged and profound neutropenia. So fluoroquinolone prophylaxis can be used for high risk patients with prolonged and profound neutropenia. Okay. Third, when the child has undergone allogenic hematopoietic stem cell transplantation, or when the child has undergone a intensive remission induction therapy, then you can use antifungal prophylaxis against candida infection. So prophylaxis against candida infection is highly recommended in the patient with allogenic hematopoietic stem cell transplantation. Okay. So this is about antibiotic and antifungal prophylaxis. So in antifungal prophylaxis, you can use the drugs such as fluconazole, itraconazole, third voriconazole, fourth capsofungin. Okay, so these are applicable. So fluconazole or itraconazole, voriconazole or capsofungin, these four are applicable for this. So in this therapy, how long you will give the patient? So duration of antibiotic therapy. So 1 week duration is given if the child is afebrile on day 3. Second, when the absolute neutrophil count has been increased to more than 500 cells per millimeter cube on 2 consecutive sampling. Okay, and the child is a low risk patient and cultures are negative, then you can stop the antibiotic within 1 week. More than 1 week has been recommended if the temperature of the child slows to settle after 3 days. If the temperature slows to settle after 3 days, for more than 3 days, you have to continue antibiotic therapy for 4 to 5 days even after neutrophil recovery. So for this patient, you have to continue antibiotic therapy for 4 to 5 days even after neutrophil recovery. Neutrophil recovery is nothing but when the ANC count is more than 500 cells per millimeter cube. Okay, this is more than 1 week of antibiotic treatment, for whom you will use a 2 weeks treatment. So 2 weeks of antibiotic treatment is used if the culture is positive, that is bacteremia is present, or the child have a deep tissue infections, high risk patients, or if the neutropenia remains even after 1 week of treatment, you will be continuing the treatment for 2 weeks of antibiotic will be used. Okay. So this is about the febrile neutropenia. So we have seen the definition, severity of neutropenia, most common organism causing, risk assessment, examination of a child, next investigations, management, and the duration, how long you should give the antibiotic therapy, and prophylaxis. Okay, this is, I've cut shorted the flow chart and everything. If you want me to tell in detail about the flow chart, please kindly write it in the comment section, or you can DM me in the Insta page or in the Telegram group. Okay, thank you so much. I've shared the PDF of these notes in a Telegram group. So Telegram group is Pete's University Exam Discussion Group. Thank you. Have a nice day.